Why don't we switch gears a little bit and talk to me about, what is in your clinical experience, practically how you're managing someone who comes in acute low back pain. Maybe they're hunched over, maybe they can't straighten up so easily, they can't move too easily. It's obvious they're in acute
Mhm.
low back pain. Walk me through, they walk in, what are you doing with them? Maybe whether or not it's particular questions you might ask them, and then how you are going to examine them, what you're looking for, and then how you are going to try to manage that acute pain in that visit.
Okay. Well, the first thing, of course, is what brought it on, because that at least might give you an indication as to whether you're dealing with a disc or disc-like problem or a non-disc-like problem. And that is important because, of course, um, the assessment of a disc-like problem usually must lead to a direction of preference that will be the basis for the treatment or the home program that the patient will go home with. On the other hand, if it is not a disc problem or disc-like problem, it is a muscle strain, the patient may have to lie still and apply some kind of pain relieving measure. It might be shortening of the muscle instead. It might be taping of the muscle or gentle movement, small amplitude movements in different directions to keep the tissue from seizing up and becoming stiff and painful. So the first thing is there an underlying problem? The second thing is how quickly, in relationship to this precipitating factor, did the pain come on? Because the longer it took to come on, the likelihood that it is not purely muscular and that you are dealing with something significantly more irritable that took a while to become inflamed, and now it's inflamed, it's rarely going to teach the patient a lesson. So you have to kind of go, am I dealing with a slowly driven inflammatory structure, or am I dealing with an acute irritated structure like a muscle, something that is tugging on a nerve, those kind of things.
That
So,
seems a little sorry. That seems a little counterintuitive to me. In
oh,
in respect of if I give you an example and say, I let's imagine this morning I wake up, I feel generally fine. I bend over to pick up my kid off the ground. I feel a sudden sharp low back pain. I
mm,
can't stand straight up. If I bend forward too much, it causes sharp pain. If I try to stand up straight, it hurts. I
mhm,
walk myself into Robert Lardner's office
mhm,
and say, yeah, it felt generally fine. In the past week, I hadn't
mhm.
really had any symptoms. It was just I bent over, picked. It seems like you're indicating that. Uh, well, I guess what would you
So,
think about that? I mean,
yeah, so you bent over, you picked up something went. Okay, you're in pain, flexion is problematic, extension is problematic. Okay, now, is the pain traveling anywhere? And again, if you hadn't done anything, let's say you worked out yesterday, you came home, and then this morning you couldn't get out of bed, that would be what I mean by a slowly inflamed injury.
okay,
It
so that's a
wasn't a,
little. The
that's right.
slowness is not that slow.
No, it's
I'm
not that
thinking months
slow,
and months.
but it's no, no, no. I mean that the precipitating factor occurred hours
Okay, okay.
before and did not even necessarily warn you at the time you did it that
You were
it
able
was
to do
going
the
to be,
workout.
you were able to do it. You finished, you showered, you went home. You felt a little stiff, but you had not done anything out of the ordinary. That's what I mean. So now, if I have the patient who says, well, now I can't move, no direction is really good. One, I have to find out by exam where most of the spasm is. I have to find out, and I always look for splinting, meaning that the spasm is occurring in one muscle and one muscle is painful, but the antagonist will have a corresponding response. And if it is painful or very painful compared to the actual painful site, I must try to break the tone between these two coupled muscles. So I will try to affect one before the other, and probably I may go after the less painful muscle first. So if I have a back problem, flexion and extension are problematic, I would probably go after and look at the abdominals to see if they are in spasm themselves and maybe contributing to the response of the back.
In reference to the paraspinal muscles, I mean, that's
Yes, that's right. In references. So there's always splinting, coactivation splinting to a protective coactivation. And if I now try to test the patient, I gather some data, global data, as best I can. And then I now try to see if the patient will change this data by flexion, extension, or side gliding. Really. Right. And if I get any inkling that this changes the data in a positive way, I start to work around that direction, however mild it might be, to break the cycle and the spasm that's involved. So that is often the case. If I have a rotational component, I will also test that. But in the beginning, I try to find the direction of preference and use that. But let's say that I have somebody who's like on the verge. Nothing, I cannot find anything. Then I will start using actually rotation, because rotation actually can break down the muscle spasm. We know that hypertonicity in the spastic muscle is diminished through rotation. And so now I can start by just having the patient rotate their neck from side to side, because that rotation requires stabilization elsewhere. It sends a synergy, however subtle, right down the whole body. You will not turn your head without affecting the whole canister as you do so.
So you're talking about, the example of having the patient rotate head side to side as a indirect treatment for somebody in acute low back pain that you can't seem to find.
That's right.
Okay.
Who is too acute for me to do much with.
Right.
So they can be in a 3-month position, and I have them look from side to side, because that requires a synergistic counter force that they must use through their body to allow this to occur.
Perfect example of how, you get the question at the DNS course, what's the best DNS exercise for the low back? And my response is the cocky, we don't have a low back exercise. We have global exercises that you can choose to focus on areas. And then I'll say, 3-month supine, you might not think is the most effective exercise for your neck or your shoulder, but it does affect those areas.
That's right.
Understanding how it affects the areas is obviously the trick.
Right.
But
so
the idea that you're using 3-month supine and rotation of the neck to treat, prone,
yes,
3-month prone.
That's right, because what does 3-month prone give you? It gives you support points that are outside the spine. So it allows the spine now some mobility that it will not have if it is the fixed point, it's not going anywhere. So if you want to give the spine a chance to move in a direction, you can unload it through putting the fixed points at the extremities. And so pubic symphysis and the elbows, great. Turning from side to side starts this mobilization function. And then you add the shoulder girdle. And once I have the shoulder girdle, the person can do this. I then put them back in prone and I start the pelvic rotation towards 4.5 months crawling. Can they roll the pelvis to one side and bring the leg up a little bit and back down and alternating? So now I have rotation and they're going from pubic symphysis to ASIS, back to pubic symphysis to the other ASIS, and bringing the leg up. And if they can do this, I then go back and I check my baseline data. In that position, I can rake the abdominal wall to see if there are any spasms in the abdominal wall.
The dreaded Lardner rake.
That's right.
The abdominal wall.
Let it not be said I shy away from that. So that is it. And this gives me, and I can also affect the hip flexors, the deep hip flexors in prone. That also gives me an information on how much are they involved in the locking up of the back. And from there, I move on to more movement. And if I can do that, I go into Cobra. And they come up on their elbows a little higher. If the muscle is spasming, I add traction, because sometimes just the traction will settle it down. Or if they cannot do an active Cobra, I put pillows under them so that I can get extension without muscle activity. That's right, you prop them in extension. If there's a disc involvement, the propping will probably initially increase the tone of the hamstrings and so on, but then it will start to come down. And that is your sign that you are to continue in this direction. And from that, I move into quadruped. And from quadruped,
you're reviewing all of prone development, prone onto.
Well, that's right. And then I have them look from side to side. So there's rotation and side bending. They look at their feet. And if I get to that point, usually they can get off the bed. And if that is the case, that's their home exercise. And then when they return, if there's a significant chemical component, let's say, then they have to have some kind of medication or some kind of chemical intervention that helps them with that. If it is mostly biomechanical, then of course sometimes just even heat or cold will help them, and we will get on with the movement aspect. If the chemical component is high, then the home exercise is kept at a minimum and the chemical treatment at a maximum. And so on. And then I expect to see them when the symptoms have less acute, and I can gather more baseline data and then I start the usual procedure of treatment of the subacute low back pain.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.